Bonjour and welcome everyone for our afternoon session and to our first panel that will be dedicated on public policy. Is everything working with the translation? Yes, thank you. In this panel on public policy, we want to look at what the public policies does to the access to healthcare for undocumented migrant and precarious migrant with a precarious residency status. So in the health policies protecting the health of migrant with precarious residency status, they are characterized by a dual movement. On the one hand, the welfare elites, the policymaker within the social ministries are designing reforms in the context of austerity, and that's one of the big challenge because the budget restrictions have a negative impact on the protection of the most precarious population, among which the migrants and precarious migrants are a great share. And on the other hand, over the past few decades, we could observe that migration policy have increasingly interfered with social policies, including healthcare policies, importing administrative categories of the migration management into the administration of healthcare that aim to limit the social integration of precarious migrants. And also we want to look in the field how the policies are reinterpreted and inflected by street-level bureaucrats. The street-level bureaucrats are the people who are directly in contact with the people going to the administration, and in our case, they are in direct contact with the migrants, the undocumented migrants and migrants with precarious residency status. So we want also to look at these actors, and we want to look at different level of understanding of the social state in order to grasp process by which policies on access to care for migrants with precarious residency status are made. To discuss this question, we have invited 3 guests. Actually, we have invited 4 guests, but unfortunately, one of our guests couldn't come. She's sick. Miriam Schüller will not be able to join us today. But we have 3 wonderful guests that we will listen to. And we will listen at all the presentation in a row. And afterwards, we will have a time for a Q&A and for discussion. So I kindly ask you to note your question during the presentation and ask them at the end of the session, and we will have like this general discussion. Our first speaker is Paul Dourgnon. Paul is an economist and a research director at Irdes, the Institute for Research and Documentation in the Economics of Health in Paris, where he conducts research on equity issues in the healthcare system. His work focuses on the evaluation of system and public policies, such as healthcare access policies, as well as on vulnerable populations. He has been working on health issue and access to healthcare for migrants for over 15 years. And from 2011 to 2015, he represented France in the European project called EU and North African Migrants, Health and Health Systems. And since 2019, his research has focused on undocumented migrants and the aide médicale d'État, the state medical aid in France. And his research often relies on innovative surveys such as the survey Premier Pas, First Steps, that has been conducted in 2019 among undocumented migrants. So Paul, the floor is yours. This is your presentation, huh? Oui, you can do your presentation in French. Tu peux aller ici, comme ça tu fais les slides. J'ai 20 minutes. Ouais. Maximum ouais, 25.
Alors, rebonjour à tous. Je suis très content d'être là, merci beaucoup de m'avoir invité. Alors dans cette présentation-là, j'ai décidé de ne pas me focaliser sur un seul des travaux de recherche qui sont issus de ce programme de recherche qui est plus large, qui s'appelle Premier Pas, hein, qui est un programme de recherche qui, dans sa phase de collecte de données, est terminé depuis longtemps, mais dont on continue à produire ça et là, et dont très récemment encore de nouveaux résultats. Je me suis proposé plutôt de vous en présenter l'ensemble, de vous en synthétiser l'ensemble, parce que ça me permettait aussi de les mettre en rapport plus facilement avec des problématiques de politique publique en France, et d'aborder les questions de knowledge transfer, peut-être de transfert des connaissances ou de l'évidence, et puis aussi parce que tout simplement ces résultats, ils ont été finalement sollicités dans leur ensemble lors de la discussion récente que vous avez, je pense, pas manqué, pour ceux qui sont français en tout cas, sur la réforme de l'aide médicale de l'État en aide médicale d'urgence. Alors peut-être c'est quand même utile de rappeler brièvement ce que c'est que l'aide médicale de l'État, parce que vous avez compris dans la brillante présentation de ce matin d'Ursula que les systèmes en Europe n'étaient pas tous les mêmes, surtout pour ce qui concernait le traitement ou l'accès ou l'assurance des personnes sans titre de séjour en Europe, dans les différents pays. Donc la France a une situation particulière. Vous savez que c'est un pays bismarckien avec à l'origine des morceaux d'assurance santé qui se sont progressivement collés les uns aux autres, qui ont mergé un petit peu les uns aux autres et qui se transforment doucement en un système universel. Et le grand pas vers l'universalisation du système, c'est 2000. C'est l'année de la CMU, hein, le moment où normalement plus personne ne se retrouve, on parlera des sans-papiers après, sans assurance santé en France, de la CMUC, la couverture maladie universelle complémentaire. Et puis leur tout petit frère à côté de ça, petite sœur, plutôt l'aide médicale de l'État. L'aide médicale de l'État, donc c'est un dispositif d'assurance de l'État, donc qui est exclusivement réservé à des personnes qui n'ont pas de titre de séjour en France, qui doivent, pour l'obtenir, démontrer qu'elles sont en France depuis 3 mois. Il y a différentes règles, des règles de revenus aussi, d'autres encore. Et j'ai trop vite, pardon, ok, je ralentis, excusez-moi. Donc l'aide médicale de l'État, j'essaie de vous expliquer que c'était donc un dispositif d'assurance publique qui permet donc à des personnes sans titre de séjour en France d'accéder à l'essentiel du panier de soins de l'assurance maladie. Je veux parler des soins primaires, des soins secondaires, tertiaires, de l'hôpital et puis des traitements médicamenteux, à l'exception notable de l'optique et puis des soins dentaires qui sont beaucoup moins bien couverts. Alors elle vient pas au milieu de... C'est pas une apparition dans le désert, hein, ça vient pas de nulle part. En fait, elle trouve sa source dans des lois qui sont hors du système de santé, qui sont la loi Pasqua de 1993, si j'ai bonne mémoire, et à partir desquelles, en fait, qui ont exclu de facto les personnes sans titre de séjour de la protection sociale en santé. Hein, avant 93, si vous étiez résidiant en France et que vous n'aviez pas de papier, vous pouviez aller frapper à la porte de votre département ou de votre conseil général ou bien de votre mairie et solliciter le médical départemental qui alors variait d'un département à l'autre, mais qui dans certains départements comme Paris proposait des garanties parfois similaires, parfois même supérieures, semble-t-il, à ce que propose aujourd'hui l'aide médicale de l'État. Bref, ce système, je passe déjà trop de temps, ça commence bien, je peux pas... voilà. Bref, ce système datait de 2000 et en 2016, quand on s'est proposé auprès de l'Agence nationale de la recherche de mener cette recherche un peu à visée entre guillemets évaluative, on réalisait que en presque 20 ans, il n'y avait eu aucune étude d'évaluation de l'aide médicale de l'État, alors que tous les dispositifs qui avaient été mis en œuvre ou qui avaient été implémentés au même moment, l'avaient été de moult fois, de moult façons. Je pense en particulier à la CMU qui avait fait l'objet d'un nombre invraisemblable, enfin pas invraisemblable, mais un nombre important de travaux, d'études et d'évaluation. Donc un dispositif très peu étudié, alors c'est vrai pas très coûteux, je reviendrai dessus dans la diapo suivante, mais quand même très peu étudié, ou pas du tout étudié même depuis 2000, et différents rapports publics, de l'inspection générale, des finances, de l'IGAS, d'autres encore le rappelaient. Une population très mal connue, c'est pour être... Oui, pas du tout connu, hein, ça aussi Ursula l'a bien expliqué ce matin. En fait, il n'y a pas d'estimation en France du nombre de sans-papiers, à tel point que très souvent, c'était, en tout cas jusqu'à nos travaux, le nombre de personnes couvertes par l'aide médicale de l'État qui fournissait l'estimation de base du nombre de personnes sans titre de séjour en France. Et même si vous allez dans les travaux du Pew Research Center aux États-Unis, qui est l'institution de référence sur les estimations démographiques du nombre de sans-papiers aux États-Unis, et puis sur les comparaisons internationales, ils reprennent assez bêtement le nombre de personnes assurées à l'aide médicale de l'État. Vous voyez vraiment rien, on connaissait rien. Et on n'était pas du tout sûr, en fait, même de savoir si quelqu'un voulait y savoir quelque chose. L'administration nous disait, ils sont par définition invisibles, on ne peut pas... il y a une forme de contradiction intime dans cette idée de vouloir mieux les connaître, puisqu'ils sont par définition inobservables. Et puis un contexte politique très particulier, je ne reviens pas forcément longtemps dessus, vous l'avez tous, vous le connaissez aussi bien que moi, à la fois conflictuel, très conflictuel et très polarisé, avec... je vais le faire de façon peut-être un peu caricaturale, mais à ma gauche, un positionnement qui est très sur les principes et les droits, et qui voudrait donc que les principes s'imposent presque au résultat, et voudrait qu'à eux seuls, ils puissent justifier du fait qu'une personne en France puisse bénéficier d'une couverture maladie. Après tout, on peut avoir le droit d'en discuter. Quelles sont les limites de la solidarité nationale? C'est une vraie question, on a le droit de se la poser. Et à l'opposé, des personnes pour qui l'existence même d'un tel dispositif ne peut se justifier dans la mesure où tout dispositif qui inciterait des migrants supplémentaires à venir devrait être supprimé. Donc on voit un dialogue à peu près impossible. Et là encore, malgré le fait qu'il y ait un large constat de manque de connaissances, on n'était pas sûr de la volonté, qu'il y ait une volonté politique derrière cela, forte, de vouloir porter vraiment le projecteur dessus. Et dans l'administration de la sécurité sociale, certains nous avaient dit, mais vous savez, c'est peut-être mieux de laisser le tapis... un tapis épais, enfin, comment dire, de laisser un peu d'ombre sur le sujet, ça nous permettra finalement de mieux protéger le dispositif et de le protéger d'un contexte politique que je viens de décrire. Voilà. Voilà comment se présente ce projet. Là encore, pour un dispositif qui n'est pas si coûteux, hein, de l'ordre de 1 milliard, 0,5% de la dépense de santé en France à peu près, mais en croissance à peu près constante depuis son implémentation en 2000. Alors, les questions qu'on se posait autour de l'aide médicale de l'État, c'était des questions d'économie. C'était pas seulement, bien sûr, combien ça coûtait, mais c'était plutôt qui y accédait, qui n'y accédait pas, et est-ce que l'AME avait l'effet qu'on escomptait qu'elle aurait sur le recours aux soins, les consommations de soins, l'utilisation des services de santé des personnes couvertes. Alors, en creux, on s'est posé d'autres questions, mais il y avait aussi une demande publique derrière, hein, qui était notamment en termes sur le fameux social welfare magnet, l'effet d'appel d'air qui voudrait que des personnes... qui auraient envie de migrer choisiraient le pays dans lequel elles voudraient migrer en fonction du système de protection sociale et notamment du système de protection sociale en santé pour les personnes en mauvaise santé. Bon, il a fallu qu'on réponde à ces questions alors qu'on n'était pas forcément, c'était clairement pas nos objectifs premiers. On a essayé de le faire avec nos données. Et vous verrez dans les slides suivantes comment on a essayé de répondre à toutes ces questions. Alors, on l'a fait à partir d'un projet qui s'appelle le projet Premier Pas, sur lequel je passe vite, hein, il est largement documenté en ligne et puis j'ai pas trop le temps de vous l'évoquer là. Mais l'idée générale, c'est que c'est un projet assez large, pluridisciplinaire, mais au cœur de ce projet, il y a une enquête à visée représentative. Alors, visée représentative, c'est pas très carré méthodologiquement, mais c'est quand même ce qu'on espère avoir fait. On a enquêté dans un certain nombre de sites, je crois que c'est le diapo d'après, voilà, un certain nombre de sites, vous voyez, aussi bien des associations que des services publics. On est même passé au bain-douche de Paris. À Paris, donc, et puis à Bordeaux et l'agglomération de Bordeaux. On l'a fait que dans ces deux endroits-là parce qu'on avait des équipes de recherche là et que ça aurait été trop coûteux de le faire évidemment France entière. Mais donc on a listé l'intégralité des sites dans lesquels on pensait que des personnes d'origine, des personnes étrangères sans titre de séjour pouvaient être parmi les usagers. Voilà, donc pas seulement des sites destinés aux soins, hein, donc pas seulement des centres de santé, surtout pas d'ailleurs même, hein, mais beaucoup d'autres sites. Vous voyez, je cite les bains-douches, des permanences d'accès au droit, je relis en même temps que vous, hein, des points d'accès au droit. Il y avait quelques centres d'hébergement, je pourrais expliquer pourquoi on n'a pas tout pris. Bref, on a demandé à toute cette liste de sites si elles accueillaient ou pas, on a fait une pré-enquête, hein, des personnes sans titre de séjour, si oui, combien. On est allé frapper à la porte de ceux qui nous disaient en recevoir et suffisamment. Et c'est comme ça qu'on a construit notre enquête, en envoyant les enquêteurs donc, auprès de 1200, un peu plus de 1200 personnes sans titre de séjour, couvertes ou non par l'aide médicale de l'État en France et donc à Bordeaux. Alors quelques résultats. Un premier résultat important, je reviens dessus parce que je trouve qu'on a fait des zigzags sur les définitions tout à l'heure. en parlant de personnes sans titre de séjour, on a souvent un peu mélangé la migration irrégulière et le fait d'avoir des papiers ou pas avoir de papiers. Là, je parle bien de personnes en situation irrégulière, et parmi elles, il y en a de l'ordre d'une moitié, pas tout à fait, qui sont venus en France avec un visa. Hein. Ce n'est pas simplement des gens qui ont pris le bateau ou leur petit baluchon et qui ont traversé une partie du monde. Pour beaucoup d'entre eux, c'est des gens qui sont venus avec des visas de tourisme, des visas d'étudiants, tout ce qu'on veut, et qui ont en fait, comme ça arrive très souvent, dépassé le terme de leur visa et sont restés. Voilà. Donc il faut l'avoir en tête parce que bien sûr, derrière ça, il y a des situations très différentes, très hétérogènes. C'est quand même important de le dire. C'est très difficile de sortir de la caricature quand on veut raconter des choses sur ces populations-là. Voilà en tout cas comment elle se construit, comment on l'a... Une photographie rapide de la population telle qu'on l'a en tout cas observé nous. Vous voyez qu'elle est majoritairement jeune, voire très jeune, mais malgré tout, il y a de l'ordre d'une personne sur 10 qui est âgée de 50 ans ou plus. Dans les diapos d'Ursula tout à l'heure sur les immigrants chinois, je ne sais pas si vous vous rappelez, je crois que c'était 1 sur 10 qui avait plus de 60 ans, ça m'avait frappé. Donc c'est pas que des personnes jeunes, elle est nettement masculine, 7 sur 10, et avec des durées de séjour en France qui ne se réduisent pas simplement à des primo-arrivants. Vous voyez que un quart est là depuis plus de 5 ans. Et des origines de migration, bon, par contre, qui sont attendues largement majoritairement Afrique subsaharienne et Afrique du Nord. Alors, le résultat fort de ce travail, c'est bien sûr que 1 sur 2 sont couverts ou donc ne sont pas couverts par l'aide médicale de l'État. En tout cas en 2019, je ne vous l'ai pas dit, mais l'enquête a lieu en 2019. On y croit à ce résultat parce qu'il est robuste, c'est-à-dire qu'on l'a travaillé autant qu'on a voulu dans différents sous-groupes, dans différents types de sites, avec différentes pondérations. C'est très solide, c'est costaud. C'est un résultat auquel vraiment je pense et sur lequel s'est appuyé beaucoup notre discours auprès des décideurs et auprès des médias aussi. Et ce qui est intéressant de voir derrière, je pense, c'est que le principal facteur qui explique le fait d'être couvert ou pas par l'aide médicale de l'État, c'est pas l'état de santé. Je vais un petit peu plus vite que mes diapos parce que je pense que j'ai pris beaucoup trop de temps au début, mais c'est pas l'état de santé. On pourrait s'attendre que des gens plus malades recourent davantage à l'aide médicale de l'État. Ça serait un résultat finalement dans l'ordre des choses. Et on n'a pas tellement trouvé ce résultat attendu. Ce qui domine, c'est 2 choses. C'est la durée de séjour. Alors la légère baisse de 70-65, elle n'est pas significative. Ce qu'il faut se rappeler, c'est qu'au-delà de 5 ans, il y a encore à peu près un tiers, 30%, un tiers des personnes qui ne sont pas couvertes. Donc c'est la durée de séjour en France qui domine, qui est le facteur le plus explicatif de la couverture par l'aide médicale de l'État. Les autres facteurs qui sont importants, ils ont trait finalement aux barrières linguistiques, culturelles, et puis donc à la connaissance finalement du dispositif, et puis aux conditions de vie en France. Vous voyez que quand les connaissances en français sont basses ou très mauvaises, le taux d'assurance s'effondre. De même, les personnes en situation de précarité alimentaire, les personnes qui vivent dans les logements de fortune ont des taux de recours à l'AME qui sont bien inférieurs à la moyenne. Et quand on s'intéresse aux motifs de non-couverture, c'est essentiellement des éléments liés à la complexité des démarches qui dominent. Certes, un tiers n'en ont pas entendu parler, mais pour le reste, c'est bien la complexité des démarches qui explique que soit les personnes n'y ont jamais eu recours, soit qu'elles n'aient pas renouvelé leur demande. Il faut rappeler que beaucoup de ces personnes-là en fait, ont d'autres problématiques dans la vie que d'aller s'assurer à l'aide médicale de l'État, bien sûr, comme par exemple celle de manger, une problématique qu'on connaît bien. Alors, en termes de besoins de soins, je vous l'ai expliqué, peu de corrélation entre l'état de santé, c'est quand même surprenant, et l'aide médicale de l'État, y compris l'état de santé dans le pays d'origine, et on y reviendra quand on parlera de l'appel d'air. Vous voyez que parmi les personnes qu'on a interrogées, seul 1 sur 10 dans des questions ouvertes, cite la santé parmi les motifs qui l'ont amené à migrer. Et parmi ces gens-là, il ne s'agit pas simplement de problèmes de santé, ça peut être le système de santé ou la meilleure santé en France. Voilà. Donc c'est un motif qui est très, très minoritaire et qui, là encore, est finalement assez peu associé avec le fait d'être assuré à l'aide médicale de l'État. Alors, oui, une petite synthèse des résultats, mais je vous ai raconté tout ça. Ce qu'il faut retenir de ces résultats, je pense, sur la couverture à l'aide médicale ou l'accès à l'aide médicale de l'État, c'est que ce n'est pas du tout un processus simple qui voudrait, par exemple, c'est ce qu'on nous a raconté un peu souvent dans les hôpitaux, que une personne n'a pas l'AME, elle tombe malade, elle a un accident de travail, elle passe au service des urgences, le service des urgences l'amène à la PASS, les services médico-sociaux des hôpitaux, et la PASS après l'amène à la CNAM qui l'assure. Bon, ça c'est effectivement une vision, ça arrive bien sûr, c'est un parcours, mais finalement ce parcours il est beaucoup plus chaotique que ça. il est beaucoup moins clair. Hein, je vous le rappelle, hein, parmi les personnes qui sont là depuis 5 ans, 1 sur 3 à peu près n'a toujours pas l'aide médicale de l'État. Et dans ce parcours, se mêlent des éléments de santé, des facteurs de vie personnelle, et manifestement beaucoup d'aléas et beaucoup de méconnaissance du dispositif et de complexité administrative qui font qu'au final, seule 1 sur 2, en tout cas en 2019, est assurée à l'aide médicale de l'État. Alors quel est l'impact de l'aide médicale de l'État sur le recours aux soins? Je parle d'impact, c'est un peu fort parce qu'on n'a pas de vraie causalité, mais d'une part, il y a des travaux vraiment sur les études randomisées aux États-Unis très récents qui trouvent exactement les mêmes résultats, et puis peut-être que l'étude Makassi pourra nous confirmer ces résultats-là, hein, qui pour le coup est une vraie étude qui permet de proposer de la causalité. Les personnes couvertes, alors plusieurs résultats, les personnes couvertes par les médicaments de l'État ont plus souvent, le cabinet passe plus souvent par le cabinet du médecin pour accéder au système de santé, ça c'est un résultat fort. Elles vont de façon généralement, elles accèdent plus aux services de santé, en ce sens qu'il y a moins de non-recours. Elles recourent un peu plus souvent aussi. Elles recourent un peu moins aux urgences, surtout avec le temps. Elles recourent également moins aux ONG, moins aux structures de la PAS, au PAS quand il y a des services de santé associés, et donc davantage au cabinet du médecin. Donc finalement, on voit que les personnes couvertes recourent plus, et elles recourent mieux, et elles recourent d'autant mieux qu'elles ont été assurées depuis plus longtemps. Hein, donc il y a une forme quelque part d'acculturation, si on peut se permettre ce terme-là, d'acculturation en santé qu'on peut observer parmi les personnes assurées. Donc vraiment des points positifs, et pour obtenir ces résultats-là, on a à la fois d'une part comparé les personnes assurées aux personnes pas assurées, facile, mais on s'est aussi dit que ça serait intéressant de comparer les personnes couvertes par l'aide médicale de l'État à un autre groupe de personnes couvertes pour l'essentiel, sauf 2 postes de soins, de la même façon, et également dans des situations économiques précaires. Je veux parler des personnes à la CSS non contributive, hein, la CMUC, okay, dont je parlais tout à l'heure. Donc des personnes qui sont pour la plupart sous le seuil de pauvreté et qui ont une couverture maladie complémentaire publique qui leur permet d'accéder à l'ensemble des soins, à peu près l'ensemble des soins gratuitement, y compris le dentaire et un peu d'optique. Et ce qu'on peut observer, on a même été surpris, hein, on a fait des comparaisons à âge et sexe contrôlés sur des données administratives, les postes de consommation de soins ambulatoires sont quasiment superposables. C'est quand même étonnant. Hein, alors qu'on contrôle très mal de l'état de santé, en fait c'est la même chose, il n'y a pas de différence. Les seules différences qu'on observe, et alors là elles sont massives, et sans surprise c'est sur le dentaire et l'optique, où les personnes couvertes par l'aide médicale de l'État consomment beaucoup moins. Et ça nous redit une chose. Alors on s'y attend quelque part, évidemment, quand on est moins couvert, on consomme moins. Mais ça raconte des choses quand même intéressantes sur quel serait l'effet d'une politique qui viserait à réduire l'aide médicale de l'État aux soins urgents. Hein, quand on réduit le panier de soins, il y a un effet très clair sur les consommations de soins. J'ai encore combien de temps ? 5 minutes ? Ok, super, j'y arrive. Alors, sans transition, je passe à la question de l'appel d'air. Peut-être que vous vous rappelez, mais j'espère que vous vous rappelez parce que c'était il y a un mois, donc c'est un peu de mémoire, que dans les attendus du Sénat, les attendus de la proposition de loi du Sénat qui avait été votée au Sénat, hein, de transformation de l'aide médicale de l'État en aide médicale d'urgence, hein, donc concentrée sur les soins urgents, les maladies graves, les maladies douloureuses aussi, si quelqu'un voit ce que ça veut dire, il pourrait m'expliquer, et la maternité. Il y avait cette idée, et longtemps répétée, au milieu de pas mal de chiffres faux, étonnamment, carrément faux en fait, que le maintien d'un dispositif très généreux serait de nature à constituer un appel d'air qui induirait la venue de nombreuses personnes sans titre de séjour et dans des états de santé dégradés. On voit l'idée. Alors là-dessus, on a essayé de répondre. On a répondu d'ailleurs aussi grâce à l'Institut Convergence Migration et son blog, puisqu'on a fait un blog là-dessus. Évidemment, on l'a répété récemment, mais tout d'abord, c'est un motif largement minoritaire. Seule, donc, je l'ai dit tout à l'heure, 1 personne sur 10 cite la santé parmi ces motifs de migration. C'est faible, et puis parmi ces personnes-là, il y en a encore 4 sur 10 qui ne sont pas couvertes. Donc on est très très loin de l'image qui voudrait qu'une personne malade foncerait traverser la Méditerranée pour aller se faire soigner tout de suite avec l'aide médicale de l'État. C'est pas ça qui se passe. Et donc, juste pour rappel, hein, les principaux motifs de migration, en tout cas parmi les personnes sans titre de séjour, sans grosse surprise, mais c'est quand même bien de le rappeler, c'est les motifs économiques, c'est les motifs politiques, C'est des motifs aussi de sécurité personnelle, hein. On peut penser par exemple aux femmes qui fuient les mutilations sexuelles et bien d'autres encore, hein. Les questions d'identité sexuelle, j'en passe. Des motifs d'éducation, des motifs de regroupement familial. Voilà. Et donc la santé, en fait, apparaît un petit objectif, une motivation presque jamais présentée seule, c'est-à-dire qu'elle vient évoquer en même temps que les motifs économiques la plupart du temps, mais qui en fait arrive très très loin derrière les autres objectifs, et là encore est très peu corrélé avec du recours aux soins et du recours à l'aide médicale de l'État en France. Autre point important, je le redis, mais c'est également ce qu'on a répété à destination des sénateurs, après 5 années en France, un tiers des personnes ne restent pas couvertes, donc on n'est pas du tout dans une situation de rush vers l'aide médicale de l'État. Une personne sur deux éligible, parmi les personnes éligibles, y accède effectivement, et après 5 ans, ben voilà, la convergence est très loin d'être parfaite. Et enfin, l'état de santé, j'y reviens, y compris l'état de santé dans le pays d'origine, puisqu'on a posé la question, n'est finalement que peu, voire pas du tout corrélé avec le fait d'être à l'AME au moment de l'enquête. Alors ça ne signifie pas forcément que les gens n'y ont jamais été, mais ça veut dire en tout cas que bon, y a tellement de trous, vous voyez, dans la raquette ou dans le suivi de la couverture qu'on ne peut pas considérer sérieusement qu'il y a, en tout cas du point de vue de l'aide médicale de l'État, un effet massif d'appel d'air qui soit visible dans aucun des chiffres qu'on a pu observer jusqu'à présent. Alors, je reviens dessus parce que c'est important. Notre étude, elle a été beaucoup utilisée, à tort et à raison, à la fois dans certains rapports, notamment le rapport de l'IGAS de 2019, dans le récent rapport E20 sur l'aide médicale de l'État. On a également été beaucoup sollicité par des députés, des médias, et donc par les personnes de l'IGAS et d'autres. Je ne vais pas en faire le résumé. C'était une expérience, c'était même plus qu'une expérience, c'était même un peu une aventure. Ça a été compliqué, on n'était pas habitué à ça, bien que ce soit aussi notre travail d'échanger finalement avec le policy maker, bien sûr. Mais les premiers échanges qu'on avait eus avec l'équipe IGAS qui a écrit le rapport IGAS de 2019, qui préconisait, si vous vous en rappelez pas, de réduire les garanties de l'aide médicale de l'État, nous avait montré qu'on ne pouvait pas forcément avoir confiance. Y compris dans des institutions qu'on pensait à peu près équilibrées. 1 minute, c'est bon, j'y arrive sans aucun problème. Puisqu'en fait, le rapport de l'IGAS avait repris, en les biaisant très sérieusement, certains de nos résultats, ce qui nous avait posé des difficultés, à la fois vis-à-vis de nos collègues, de vous, quoi, hein, quand même, parce qu'on s'était senti un peu, on s'était fait avoir, quoi, voilà. On s'était senti un peu trahi, disons, et puis ça nous avait aussi un peu mis en difficulté dans notre capacité, la volonté qu'on avait d'échanger quand même avec les pouvoirs publics, les gens qui prenaient des décisions, parce qu'on avait quand même l'intuition que c'était aussi notre travail et un des résultats que devait avoir ce travail. Donc ce qu'on a essayé de raconter, de notre point de vue d'économiste en tout cas, sur cette idée de réduire l'aide médicale de l'État à une médicale d'urgence, c'est qu'il n'y avait pas d'effet à attendre sur les flux migratoires, je ne vais pas y revenir, je viens d'en parler. Un effet sur les finances publiques à peu près nul, ça il y a également des études en Espagne qui ont pu le montrer, le fait de déporter des soins de l'ambulatoire vers l'urgence, ce qui serait probablement le résultat d'une telle politique, aura probablement aucun effet en termes financiers, parce que c'est beaucoup plus cher de soigner des gens à l'hôpital que de les soigner dans le cabinet du médecin. Il y aura très probablement, en tout cas c'est ce qui a été également observé en Espagne, un effet négatif sur l'état de santé des personnes en titre de séjour. Et là, c'est l'endroit, je pense, où on a quand même, nous, un peu de pouvoir. C'est que moi, je ne me suis pas gêné pour expliquer que si jamais une réforme comme ça aurait lieu, eh ben, je serais complètement dans mon rôle d'en évaluer les conséquences sur l'état de santé des personnes sans titre de séjour, avant et après. Et qu'on verrait qui prendrait le risque de se retrouver avec les mains un petit peu saignantes. Voilà. Je n'ai pas du tout dit tout ce que je voulais vous dire. Peut-être que j'aurai l'occasion de le faire dans les échanges. J'espère que ça vous a intéressé. Voilà. Merci.
Merci beaucoup, Paul. Je vais m'en occuper. Thank you very much. Yeah, now we welcome our second speaker. It's Reinhard Schweitzer. Reinhard Schweitzer is a research associate at the Barcelona Center for International Affairs and also research associate at the Sussex Centre for Migration Research in Brighton, in the UK. And he holds a PhD in migration studies from the University of Sussex. And from 2018 to 2020 was a Marie Curie Research Fellow at the Department of Political Science at the University of Vienna. His research focuses on the politics, practices and challenges of governing international migration across different political and administrative levels, geographical context, and institutional settings. So from an interdisciplinary and comparative perspective, it studies legal frameworks, everyday practices of policy implementation, and ways in which migrants themselves perceive, use, and bend or resist the rules and restriction imposed on their mobility and integration. So he co-edited an open access book on the politics of disintegration, and he wrote a book on the micromanagement of irregular migration that was published by Springer in 2022, and I think that's the topic of your talk. Then the floor is yours for the next 20 minutes.
Thanks a lot. Thanks a lot for the kind introduction, Jeremy, and for the invitation to all of you. It's a huge pleasure to be here. I've already learned a lot, and I'm sure in the rest of the day and tomorrow I will learn more, and I hope that I can also make a small contribution to our debates here. I'm not very used to speaking with a microphone, but I'll do my best. As Jeremy said, the book that was published last year is the basis of this presentation. It's a book on the so-called internalization of immigration control, so the process through which the border is slowly, not necessarily moving, but expanding from the territorial edges of the state into our everyday lives. More and more spheres of life and everyday social interaction between all different kinds of people, and that includes different spheres of public welfare provision, which is what I focused on. So I wanted to know how this internalization really works in specific contexts, how far into society and institutions this immigration control can go, and what happens within the institutions like schools, hospitals, etc., when they do become part of the border, which now more and more is a little bit everywhere, as Etienne Balibar, I think, once wrote quite famously. The underlying project is my PhD research conducted a number of years ago, so that's also a caveat to have in mind, that I won't focus too much on the empirical side of it, also because I know that a lot has changed in the meantime. So my contribution is more conceptual. I have tried in the book to provide an analytical and conceptual framework for studies of these issues, not necessarily just in healthcare, not necessarily just in the countries that I looked at, and that will allow systematic comparisons between contexts, but also across time, which is something that I have not done, but that I think would be very valuable in this context. So the more concrete research questions were which concrete mechanisms help and which hinder the internalization of immigration control into different institutional settings, and when and why do individual actors who work in these settings use their own agency, including professional discretion, to contest or reproduce exclusion towards irregular migrants. The empirical basis is mostly a qualitative in-depth study of 2 cases. I've spent about 8 months collecting data in Barcelona and 8 or 9 months in London. Conducted lots of interviews, mostly with street-level bureaucrats that Jérémy already mentioned and defined. Also migrants in irregular situations and various intermediaries, including, above all, NGO representatives working with these collectives. It's a double comparative research in the sense that I've looked at 2 cities within their regional and national contexts. So a lot of the thing that shapes what people do on the ground comes from national legislation, a lot of it also from regional legislation, but also municipal rules. And I've looked across 3 spheres of public service provision today. Of course, I will focus on healthcare, but the study included healthcare, education, and social assistance as three different areas in which a very similar thing is happening. As I said, the focus is on street-level bureaucrats, famously defined by Michael Lipsky, as people who do not just implement policy, even though that's their primary role, but in implementing policy, taking everyday decisions regarding their individual clients that they have in front of them, they also effectively make policy. So it makes a lot of sense, and I combined as a bit of the theoretical groundwork for the studies, basically a Foucauldian understanding of power that is not exercised directly by the government onto an individual member of the population, but through more complex ways, by structuring the possibilities that people have for possible actions to take. And here, the street-level bureaucrat is in a very interesting and important position as a kind of intermediary. Hannah Jones wrote an excellent book on this, taking this Foucauldian perspective and applying it to different street-level bureaucrats not working in migration control, but in diversity management, I think it was, where she describes these people as being in between. They're being managed by the state, but at the same time they manage the population on behalf of the state. So they're being managed and managed at the same time. I've also drawn theoretical insights from organization studies. And if you do look at the internalization of migration control from this perspective, then it becomes very obvious that the logic of migration control works as a new institutional logic that is implanted, so to say, introduced into a concrete institutional setting that already works according to important logics that make a lot of sense for the system to work according to these logics, and then starts to compete with some of them. There are also overlaps, there are conflicts, and these new logics, according to organization studies scholars, have to be enacted by concrete individuals working on the ground. So no new rule has any effect by itself. Somebody has to change their practice towards a patient in this case in order for any new rule that a government makes to have an effect. And so an important part of the whole process, which is what I have focused on a lot, is what I call in the book the micromanagement of irregular migration, which gave it the title, but and by which I understand basically this either formal or informal consolidation of a governmental logic that demands the exclusion of a person from the territory of a state where she is an irregular immigrant, with the subjacent pressures, various subjacent pressures, for the inclusion of that same person as a local resident in the municipality, as a neighbor, patient, student, friend, and so on. And the people who work in public welfare institutions very, very often have to manage these contradictions, which is a very difficult task. Also very important to remember that migrant irregularity, of course, is an invisible marker. It's not for now, at least, written on anybody's forehead, but just codified in specific documents that not very many people have access to in their day-to-day work, have neither the means nor the authority to ask for documentation that would then really certify legality or illegality of status and stay. And so the street-level bureaucrats that I've looked at very often are in a situation where they face a person who might or might not be an irregular migrant, and they face 2 key questions, I think. Should I know the immigration status of this person? And if yes, how should I find out? Is that relevant for me in any way? And then if I do know, or if I happen to find out, should I tell this to anyone? And if yes, who should I tell this to? And these two questions are the basis for a very simple analytical framework, 2 dimensions, that allows to place individuals working in a hospital, in a school, in a social welfare department, in each of these 4 sectors. That's how the framework started. Where in sector D they have no need to know, don't feel like having to know whether or not the person is an irregular migrant, and they wouldn't tell if they find out. It's just irrelevant. In sector C, they will want to know whether or not, because, for example, they need this information in order to be able to put this person in a in some kind of system. The person needs a number that they will only have if their immigration status is regular. Sector B would be the situation of a policeman, potentially, whose task is not necessarily to find irregular migrants, but if they do a traffic check and happen to find out, then there will be an obligation for them to pass this information on. And sector A would be the position of somebody who really works as an immigration officer within a hospital or a school. And especially in the case of London, I can already say that there are people put in this position. Of course, reality is significantly more expensive, more complicated and complex to break it down in 2 simple yes/no questions. So in revising the manuscript, I've also accounted for that and added a little bit more of a fine-grain analysis to that. I've basically splitted the yes into deputization, which is the absolute obligation of someone to either know or tell. So it's a legal obligation. And responsibilization, which is slightly softer. People are encouraged by the state or another authority and provided tools and told that this is an important part of their work. Nothing happens to them if they don't do it, but they really, really should. And the no side of things I divided into autonomization, and these 3 first categories are based on Walsh. It's a definition that doesn't come from me. And he calls this autonomization, where people decide for various reasons for themselves without an obligation or encouragement by the state that they want to find out what's the immigration situation of this person, or they might want to take the step and inform in order to get rid of a person that they find difficult to treat with, that they feel takes away resources that somebody else should be getting, and so on. And the last category is what I call shielding, just as a way of having a clear opposition to deportation, where there is a legal and or technical prohibition of somebody to either know or tell. So they cannot find out, they must not find out. It's illegal for them to inform the immigration situation. So the idea of a firewall, basically. I've also differentiated between 3 different kinds of welfare personnel. The professionals in all 3 sectors, professional providers, so doctors, nurses in this case, service administrators, mostly including reception desk staff, school administrators, enrollment, people who sit in the offices and do the numbers and find the administrative side of things, and then a 3rd category of people who appeared in my research very often in London, but also in some cases in Barcelona, who really are put in place. They work in a hospital, they are not home office or immigration staff, but healthcare staff. They work for the healthcare system, but the task is really to deal with the situation of migrants in general, very often of irregular migrants. And so here, part of their task is really something that would sound, if they tell you their daily work, as is something that you would expect of somebody, of a border guard who sits at the border. So these are interview quotes with one of in the UK they're called the overseas visitors managers. Every hospital in the UK nowadays has a whole department for this task, which is basically to find out the immigration status of people who they have to treat. In this case, it's a concrete case at a maternity ward. So that's something, if a woman gives birth, they will be treated, but they will also have to be charged. And so the task of the overseas visitors manager is to go there, certify the immigration status, yes or no. If they have an immigration status, this will be covered by the public system. If they do not, then they will have to be issued a bill. And if they don't pay the bill, the information will more or less automatically passed on first to the Department of Health, the Ministry of Health, and then to the Home Office. And so it will be cross-linked with visa data, and so this is why, as an example of why this category of workers is placed in Sector A and where it is placed in the framework. And so it's also a bit of an idea without going too much into detail. Here we have, it's the results, so to say, a visualization of the results of my qualitative study. The basis for something like this could also be a self-assessment. I could also send around a survey among all healthcare workers in the UK, asking them to place themselves in relation to these two questions. In this case, it's my assessment based on a number of interviews where they explained me their tasks and their position relative to migrant irregularity in their day-to-day work. And this could be repeated at a different point in time. It could be done in different cities in the same country to see if there are differences. And the same analytical framework also works at an institutional level, where the questions would be: does access depend on immigration status, yes or no? And is there not an effective firewall in place so that this information is being passed on to the immigration authorities or not? With a range of different outcomes that I've tried to summarize here in the different fields. So that basically range from formal exclusion from the service, and not only that, also by going there and trying or even getting information, you risk increasing your deportability, the chance of being deported or put in detention, receiving other sanctions for being in an irregular situation. And the outcome slightly different. In the case of the Sector B, a service can be accessed. Access formally does not depend on immigration status, but there's no firewall, and so going there, depending on who you find or who finds you, it might well increase deportability. So that's a case of informal exclusion, where it's very, very risky to actually make use of this right that you're granted to use the service. And in the case of Sector C, it would be, it's also a case of formal exclusion, but at least you can go and inform yourself, and somebody can tell you, no, here it doesn't work, but you can go to the NGO, as we've been told, without an acute risk of also putting your whole situation and stay in the country into danger. And only where both questions are responded, so where there is a firewall and the service does not formally depend on a legal immigration status, a formal inclusion is possible, and that can work through something that I described as micro-regularization. I fully agree with what has been said, that regularization of status is the only real solution to this situation. But there are possibilities, and in the book I highlight a number of them, where the system itself, the healthcare system, for example, finds a way, and that would be a fourth strategy to your to the sequence of the three possible solutions, Ursula, that you mentioned in your talk: functional ignorance, structural compensation, informal solidarity, and where the system finds a way to really regularize, just for the purpose of being able to deal with this person, the situation. Where people then told me in the Catalan healthcare system, for example, found a way at the time countering a restrictive national healthcare reform, where for them, the patient in front of them is not anymore irregular as a patient. They don't do anything about their immigration status, of course, but they can issue them a health card. They have all the numbers they need to put in their systems, and so forth. These are the results for the institutional level, where basically you see that the differences in Primary healthcare and compulsory education are very small, whereas the differences between the two countries or cities, whereas the differences between secondary healthcare and even basic social assistance are quite significant. And I will end just to give you an idea of what I also did in the book, is find and trace a lot of the different mechanisms that lead individual actors in these different roles to actually becoming part of immigration control. So sometimes without realizing, sometimes without being very much aware, sometimes because they did feel it actually makes sense to them. And often it's because of a lack of knowledge or because of a very explicitly hostile discourse about the presence of irregular migrants in our society. Sometimes because something about irregularity makes serving them as a patient or a student or whatever client more difficult. It's not really the fact that they are in an irregular situation, or even less so that they are a migrant, but because something in the interrelation between that and the system that receives them administratively creates difficulties that then cannot really be resolved. And often there are overlapping logics where a teacher, for example, works, or where in the healthcare system it is important to be able to trace a patient and to know his or her history, and that often not being possible by people who change a lot the healthcare center because every time they are afraid of being detected when they go there again. And so there are sometimes reasons for being complicit in excluding them that come from within the institutional logics that the people work in, so within the systems, and are not only imposed by the immigration regime. And very often it's indirect, often financial pressure that is put on the university as an institution, on the hospital as an institution. They are basically told, treat whoever you want, but if you treat an irregular migrant, you pay the bill, and the hospital doesn't have the money for that, and that's why the hospital said, we need an overseas visitors manager to check the passports and tell these people that they will need to pay the bill. It's not that the Home Office said you need to control this. So why does this matter? One thing that very clearly came out of this research across both settings and across all the different spheres of service provision is that the better any welfare institution gets at controlling immigration, the worse it gets at providing its actual service for the population. And it provides this service not only for irregular migrants or migrants, but for the whole population. And the effects of having to do the migration control part on top of this service is quite significant and leads to a reduction of service quality also for everybody else. The reason for, so the having separated the having to know from the having to tell showed me that it's very often, sometimes it's quite easy to convince people that they should know, or sometimes they themselves feel that they should know, and it's then also easier to make them believe that it also makes sense to, if you already have this information and there's another government department that's responsible for this, then please tell this department. It really makes sense for everybody to solve this situation. And that then undermines the trust. And that's one of the most basic and important mechanisms behind this. It will not be new to any of you. That more controlling immigration reduces trust, not only in the concrete person in front of you, the doctor, or the reception staff, that you should also be telling the whole story about yourself and your past medical history at least. But also the institution as a whole, and also the trust in the end in the healthcare, the public healthcare system as such. And I stop here and leave you with the bibliography, but probably this will be shared at some point anyway.
Thank you very much, Reinhard. That was a very interesting talk. Thank you so much for sharing your research with us. Don't want to lose too much time, and I would welcome our last guest for this session. It's Francisco Javier Moreno Fuentes, and I think he goes by the name of Javier. He's a senior researcher at the Institute of Public Goods and Policies of the Spanish National Research Council, and he has a PhD in political science from the Universidad Autónoma of Madrid. And between 2018 and 2019, was deputy director of the Spanish High Commission against child poverty. He held a visiting position in different international institutions, Harvard and Sciences Po Paris, and he has been a researcher for the European Social Policy Network of independent experts on social protection and inclusion of the Directorate General for Employment, Social Affairs and Inclusion of the European Commissions since 2014. And your main research interests are comparative analysis of public policies with a special focus on immigration, welfare regime, healthcare and urban policies. And the floor is yours. I just put your PowerPoint.
Thank you. So, well, first of all, thank you everybody, and thank you the organizers for giving me the opportunity to tell you a little bit about the conclusions or learning lessons we could extract from the Spanish case. So I will be basically talking about the Spanish case all the time, but my main point are building on the arguments that have been presented earlier today. I think the complementarity of the presentations is pretty good. So building on those concepts, come out with some ideas that I think can be useful for analyzing or looking at other cases beyond the Spanish one that I will be talking about more specifically. So this takes some time. Okay, so the way I'm going to structure my presentation is I will start by telling you a couple of things about immigration in Spain. Then I will tell you a little bit about how did we expand access to the healthcare system for undocumented migrants in Spain. And then I will enter into the specific topic of politicization, which I think is a key factor. It has been addressed earlier, and I think it's quite clear, we all have it in mind. The reason why the access of undocumented migrants to healthcare systems in Europe is a problem today is because it's politicized. Otherwise, there is no problem. There is no economic problem. It's actually, as it has been said, and we all know here, it's actually extremely positive that undocumented migrants access the healthcare system. The only reason why it's conceptualized socially as a problem is because certain political entrepreneurs have convinced significant sectors of the population that this is a problem. And as we know, in societies, a problem is not because it exists objective, but because people believe it is a problem, and therefore they behave as if that issue is a problem. So then I will talk a little bit about how the access of undocumented migrants in the Spanish healthcare system has evolved in recent years, and basically one of the conclusions of my presentations is it is very difficult to change the way a healthcare system works. So when we want to expand rights, it's difficult, but also when we want to restrict rights, it's difficult. So this can be good and bad, depending on what are we trying to do, right? So when we are trying to expand, if this is slow and painful, it's bad. But when this happens when we are trying to restrict, this is actually a good thing in practical terms for the access of these populations to this particular right. So let me start by saying a couple of things about immigration to Spain. It's interesting to think or to know that Spain was a sending country all the way until the early 80s. So we are pretty much a newcomer into the immigration world. Up to that point, we were sending migrants in big numbers to other parts of the world. So just to give you one piece of data, in the year 2000, only about 2.3% of the Spanish population was of immigrant origin. Only 1 decade later, this percentage had increased to more than 12%. So the number of foreigners multiplied by 6 in just 1 decade, okay? And this is a pretty significant event. There are few countries that multiply their population of foreigners in such a short period. So this is why it's interesting in a way to look at the Spanish case. Up to that point, or after the 2010s, basically Spain has had more or less the same number of foreigners than most Western European countries with similar levels of socioeconomic development. And of course, the key factor, and it has been very well said by Ursula this morning, why this migration has happened is because it serves to counterbalance the socio-demographic trends that Spanish society is experiencing over the last decades, right? Which means, on the one hand, expanding life expectancy, which is a good thing, and very low fertility rates, which is not such a good thing. Well, depending on where you are in the world. I don't have children, I don't like them, so for me it's fine. But for many people who want to have children, this is actually an issue, right? And fertility rates in Spain are very, very low. It's 1.25, so it's one of the lowest in the world, together with Italy and Japan. So it is an issue when you look at the demographic pyramid. The dark colors is the demographic structure of Spanish people, right? And the transparent lines is the age structure of migrant populations. So in a way, when I look at this pyramid, what I see is a pyramid that is totally unstable on its own, and migrants are like pillars, puntals on the sides, kind of holding it together, right? And this, everybody knows this. So this is in a way why the politicization, of which I'm going to talk about in a minute, in Spain of migration has been relatively slow, and it didn't take hold until very recently. So how is the access of migrants into the healthcare system? First, I need to say a couple of things about the Spanish healthcare system. One other interesting thing about Spain is that we used to have a healthcare system that was like the French one, but in the 80s we moved towards a healthcare system that is like the British NHS. So we have changed basically the DNA of the system. Well, this is easier said than done. So one of my concepts I want to emphasize is the concept of path dependencies, or which we talk about in political science, or what we could translate as inertias, institutional inertias. It's very difficult to change one healthcare system. So in fact, since we said we are going to have a universalistic healthcare system in 1986, until the system became really universalistic, it took us basically 24 years. Okay, it was only after the 2010s, early 2010, sorry, it was exactly in the year 2012, that we really reached universalization, meaning 100% of the population living in Spain, regardless of their administrative status, had access to healthcare. Okay, it took us many years by adding layers and layers of protection to different groups that have been kept outside in different moments. So that is one thing. The second thing that is important to understand is that the Spanish healthcare system works in a profoundly decentralized manner. And by this I mean that Spain is pretty much a federal state. It's not labeled as such, but it operates as if it was a federal state. So that means that the authority, the power to coordinate, to function, to run the healthcare system is given to the regions. Okay, the Ministry of Health has very little capacity to control what happens in the regions. The Ministry of Health establishes the basic law, the basic regulation, but after that, every region can do pretty much whatever they want. And this is an interesting thing I'll come back to later on. So, how is the access of foreigners to the healthcare system? Well, if you're a legal resident in Spain, you have the same entitlements than autochthonous populations. Okay, so no distinction. If you have a residence permit, you have the same rights than everybody else. So basically, universalistic healthcare system. What happens to undocumented migrants? Well, since the year 2000, the law which was passed in the year 2000 to regulate the situation of foreigners in Spain, the healthcare system was expanded also to undocumented migrants. The only requirement is, in theory, okay, is for you to be registered at a municipality, right? And the only condition to be registered in a municipality is to prove that you live in a particular address in that municipality. They should not ask you for any other document, right? So with that piece of paper, which you can get very quickly, you can then go to the healthcare system and say, okay, this is my address, and now I want my health card, okay? That is the theory. Why am I stopping here for a second? Because it's actually a little bit more complicated than that. Why? Because we came from a social security tradition, right? So in practical terms, in order to get your health card, in theory, according to the new philosophy of the system, you should just go, show your address, and get it. But in practice, it doesn't work like that, because the inertias make you have to go to the social security system to get a paper saying that you are paying the social security. Well, of course, if you are an undocumented migrant, you are not paying social security. So they tell you, okay, I cannot give you that, so you go to the social services. And they tell you, they give you a paper that says that you are not paying social security and you don't have income, and then they should give you one. Okay, so you need to go to several windows, and after that, you will go to the healthcare system, show them all these papers, and they will give you the health card. So basically, what I'm saying is there used to be, and there are still, different loopholes, different holes in the system that prevent automatic access because of the inertias from the previous institutional settings that existed before. Okay, so that was the situation between the year 2000 and the year 2012. What happened in the year, I'm gonna skip this. What happened in the year 2012? Well, as you know, terrible economic crisis starting in 2008 in the US and very quickly spreading towards Western Europe. In the year 2010, Spanish economy was already in pretty bad shape, and the finances in not only in Spain but on all the countries on the periphery of the Eurozone was very problematic, right? So we had to start cutting down on public policies very drastically. In the year 2012, right-wing government identified this situation as what we could call, again, using political science concepts, as a window of opportunity for reform. The Conservative Party didn't like the presence of undocumented migrants in the healthcare system to start with, right? They had opposed the measure, but they were in a minority, so they could not prevent it from happening. So they found this opportunity as the perfect context in which they could do what they wanted, which was, on the one hand, expelling undocumented migrants, and even more to the point, what they really wanted is to dismantle the universalistic healthcare system. So what did they do? Something extremely weird, which was go back to a logic of insurance, right? So what did they do? They said, okay, from now on, in order to access the healthcare system, you need to be either an insured person, meaning a worker, or a beneficiary of someone who is working, right? They went back to the concepts that existed before 1986. But the financing of the healthcare system has nothing to do with the social security. So it's not going to depend, the money to finance healthcare is going to come from the general taxes just like before. So they kept the funding, the financing, as a universalistic healthcare system, but the entitlements were returned to the social insurance logic. What happened at that point? The entire healthcare system got short-circuited, right? Like we have been building for more than 20 years on transforming a social insurance into a universalistic, and now they wanted to go reverse over immediately, right? So the whole system got into a collapse. Like, what do we do from now on, right? The main argument was, okay, because by doing this, we are expelling undocumented migrants. And the order from the Ministry of Health was, there are 160,000 undocumented migrants that we have registered benefiting from healthcare, and we want all of these cards cancelled and removed. Okay, we want all of these people out of the healthcare system, except in certain circumstances like pregnant women, children, infectious diseases, and of course, emergency care. So what happened after that? Well, this law was not applied. This kind of reverse thing didn't happen in practice. Why? Because the 17 regions said, I don't know how this is going to be done, and I don't like it very much either, right? Some were explicitly outspoken, we are not going to do this. Others were saying, maybe I will do a little bit, but not too much, not to get into difficulties with actually the problem of handling populations not properly care. And others were saying, oh, I'm going to follow the rule strictly and according to the spirit and the letter of the law, but very quickly they realized this is too problematic and it raises too many problems, so they started backing up very quickly. So what this produced was, in the first instance, institutional chaos, like every region went their own way, and very quickly all of the regions kind of backing down from the measure. But it still had effects, and the effects had to do, as I will go back later in my conclusions, to the point that this indetermination, this kind of lack of clarity about what is it that we should be doing, open many more rooms for discretion. So following this chaos, central government saying one thing, regional government saying another thing, put street-level bureaucrats in a position which was extremely uncomfortable, and it gave them much more power to decide on the ground and depending on each specific case, what were they going to do, right? So it opened many more rooms for discretion. Bottom line, my argument about why this measure was taken and which could be the future for the access of undocumented migrants to healthcare in Spain, but also in other countries, has to do with, as I said earlier, with the concept of politicization. Politicization basically means that the issue of immigration is in the political agenda, people are talking about it, people are discussing about it, and this is transformed into a problem. From a process, is reconceptualized as a problem. And in that process is where certain, what we call political entrepreneurs, can obtain credits from pushing forward an agenda that is restrictive. Okay, as I said at the very beginning, I don't think there is absolutely any evidence that shows that cutting down access of undocumented migrants to healthcare has any positive effect in terms of savings or in terms of controlling migration or anything. So this is done only for obtaining political credit, right? So if we know this, at least we know what we are facing. Okay, let's not spend much time about discussing the costs or the implications for the functioning of the systems. We know perfectly well the only purpose of this is to obtain political credit. So just to tell you a little bit about Spain, the interesting thing is that we didn't have a right-wing anti-immigrant party in Spain all the way until 2018. So in a way, this measure by PP, by the Conservative Party, was actually was taken to some extent to kind of build or obtain credit from the gradually emerging attitude of rejection against migrants, but there was not formally organized political party mobilizing this particular discourse. This was only happening after 2018 with the emergence of the political party that we know today as Vox, right? And now we have converged with the rest of Europe. So what was called the Spanish exceptionalism, it's already gone. Okay, it doesn't exist anymore. So now we are just like any other European country with an extreme right party, with mobilizing anti-immigrant discourses. The reason why there was not anti-immigrant party before, I don't bore you with, but basically some people, we don't know, right? But some people say it's because we had 40 years of Franco, but so did the Greeks and the Portuguese, and they had extreme right parties. Another argument was the complexity of knowing what to be a Spanish is, and this is actually true to some extent. It's difficult to know what a Spanish is, considering that some people want to be only Catalans, or they want to be Catalans and Spanish, others don't care. So it's difficult to build a nationalistic agenda in a country like Spain compared to a country like France, which is built on a very specific model of what it is to be a citizen of the Republic and so on. And most importantly, what I think is the key factor is we didn't have a skillful political entrepreneur mobilizing anti-immigrant discourses all the way until now. Now we have it. So now we can see the process evolving in a similar way. Just to give you one more anecdotal point, the key factor why Vox exploded was basically the Catalan pro-independence movement, which basically created the grassroots for the emergence of these strong pro-Spanish nationalistic feelings among certain sectors of the Spanish population. So, as I was saying before, the Royal Decree 16/2012, which is the law that expelled undocumented migrants from the healthcare system, created this vacuum or this space of indetermination that allowed for street-level bureaucrats and regional authorities to decide on how to respond to the demands on healthcare coming from these groups. And it produced all kinds of random responses. In some cases, people who had the right to access healthcare, even after this law, was refused. In other cases, people who were supposed to be refused according to law, they were actually included because the professionals opposed the implementation of that particular law. So in a way, what I think is interesting to keep in mind is that when we talk about administrative discretion, we can imagine both restrictive and what we could call expansive administrative discretion, right? So it can go both ways, and it depends, of course, on the person, but it also depends on the atmosphere, right, or the sign of the times, what is being discussed, how is the social perception of something that influences very much this room for discretion. So just to maybe say a couple of things about conclusions, this 2012 law was actually cancelled once the left-wing parties got into government again in 2018. So now we are in principle back into the situation that we were before 2012, but the system is even more confused than before, because now we have dismantled this regression into a social security system. So now we are back into a terminology and concept about universalism, but still, in a way, we could say that by forcing the joints of the system, the holes in between have become a bit larger. So now there is more plurality of behavior by regions. There is still loopholes and holes through which undocumented irregular migrants kind of don't materialize the access that in theory they are entitled to. And there is a demand for the authorities to actually come out with a new public health law, that the first one is from 1986. So to make a new one that clarifies the mechanism and clarifies the actual philosophy of the system, to make it really like an NHS system, right? Or at least one that resembles more that. And I think I will stop there because everything else I have already said. Just to conclude that, bottom line, when we are talking about healthcare systems and welfare in general, legitimacy is the key factor. To what extent people actually support the system, to what extent people believe in the system and is, bottom line, willing to pay taxes to maintain the system is absolutely fundamental. And with these kind of shifts, the healthcare system has experienced significant damage, particularly because of also the financial cuts, and in Spain in particular, we have experienced a move towards private insurance. So now in the more developed parts of the country, people are buying healthcare insurance on the side because they want to skip the waiting lines and so on. And as a consequence, the support for the healthcare system, which was very strong before 2010, has deteriorated quite significantly, and now more and more people are going towards the private healthcare system, which bottom line is what the right wanted from the very beginning, when they started kind of cutting down funds and dismantling the universalistic philosophy of the system. So I stop there. Thank you so much.
Presentation and very much for this research, because I think it is a really groundbreaking research, and I think that's not happening a lot in the research, that we have like research that gives so much new data. I remember that there was like so much people waiting for the result of the research coming out. So much new results about the health condition, health practices of undocumented migrants in France. And I would like to ask you one question about the reception of the research. You already told a bit about that. About how this research has been received in the political arena and how it has been used, and in each way, maybe if there was like actors, I would be interested to know if there was like political actors that turn around the results of the study to make an argument against the state medical aid. And I would be also very interested to know if it's something that you think about conceiving the research. Is it something in the research team, if you discussed about what could be the political consequences of doing a research on undocumented migrants? And if also, I would also be interested to know if like this discussion before, if there was like correlating with the reality after doing the research, or if there was like stuff that you didn't think about that came out after the research. That would be my question. I go around for Reinhard, also thank you very much for the presentation. I had the chance to read your book some years ago on the micromanagement of undocumented migrants. I really enjoyed the read. I worked also a lot on street-level bureaucrats in the healthcare system and how they are dealing with migration and managing migration and I really liked also the comparative idea, like to compare UK and Spain, and I think that's two models that are so different that must have been challenging to do the research. And I was wondering if like this general attitude of the system in which the street-level bureaucrats are acting, like this general attitude that from Spain that is more migrant-friendly, and in UK that is more migrant-unfriendly. It's maybe a euphemism. How did you see the impact of this general context on the street-level bureaucrats? And I would be interesting, maybe more in the UK, in this institution that are not excluding irregular migrants upfront, how the street-level bureaucrats saw their role in the management of migration. If they see, because of this really anti-migrant sentiment, if there was more present than, for instance, in Spain. And also, I don't know if you have some results on that, but I was wondering if, like, the deservingness of the migrants was an element that came in the discussion that you had with the street-level bureaucrats, and if there was not only to uncover undocumented migrants and to report them to the institution, but also if they were doing, like, playing with their room from maneuver and making differences between the undocumented migrants, between deserving and undeserving migrants, and if they had, like, if they were walking with this notion. And for Javier, I have also one question. Thank you for your presentation. I think that was really interesting. I really enjoyed that you said at the beginning of your talk that policies are really hard to change, and especially if they are, like, in the system for a long time. That was also my feeling with the state medical aid. When there was, like, this debate to suppress the state medical aid, I was thinking, okay, it's there since 2000, and I think it's so much there that it will not that easy to, and there was many attempts to suppress the state medical aid, and each time it fails. And I think that when policies are institutionalized and are coming into practice, it's getting very much difficult to suppress or to change this policy. And I wanted to ask you, and I found that really interesting in your presentation, is the role of the local government. We don't have that in France, so we don't really aware about federal state and how the power relation between central state and federal state and local government are interplaying. And because for this reform of '92, there was the local governments played a big role in breaking the reform. And I was wondering what was the argument that the local governments were using, if there was also there in the local governments a more friendly, migrant-friendly discourse. And one last question would be about the value of universality that seems to be really very central in the healthcare system in Spain. Was the value of universality and like the protection of healthcare as a human right something that was present in the debate? And is this something that is decreasing as a value in the debate, or is it something that is still present and that allows Spain to have, like, still such migrant-friendly system? That would be all. Paul, tu veux commencer?
Thanks. Vous m'entendez? Okay. In English, maybe? So you. Y a-t-il un message subliminal dans ce commentaire? In English then? Okay, I'm not sure I'm going to speak slowly, but I will try though. So there are many ways to answer your questions, but the easiest I think is to tell you about what we did recently. Is that there's been a very high number of press releases that took into consideration our results. I mean, since 2019, I think we produced as many as 7 policy briefs, and we had hundreds of press releases. And I recently had the curiosity to take a look at how many and when. And I was very surprised, actually. So there are 3 peaks, like by the hundreds. In 2019, actually had the releases of the first results. Then 2022, why? I will tell you later. And then very recently, 2023. Well, the years do not really matter. What matters is the month. All of the peaks were in November. So there was a huge November effect. So basically, when you're looking at the statistic, it's like bottom, 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 skyrocket, bottom, 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 2 years, skyrocket, etc. So 2019, it's easy. You have the report from the IGAS, I'm switching to French right now, l'Institut de, l'Inspection Générale des Affaires Sociales, sorry. Well, whatever bureaucratic report on the state's medical aid at the very moment that was released, at the very moment when we were releasing our own results. So then, of course, tons of press releases. No, that was expected, if you will. 2023, this very month, then again, there is this proposal of reform, of actually cut of the state medical aid into emergency medical aid. And of course, they took lots of our results into consideration, and we published again. Actually, we took this into consideration, and we decided to publish more in order to have an impact, make a difference. But then what happened last year? Actually, what you have to know that in France, something very important, I guess, is happening in November. It's called the PLF, le Programme de loi de finances, if I'm right, which is basically the moment when all the social laws and programs are discussed at the Congress. The big money moment. And that's the moment when actually social security laws are discussed, migration laws are discussed. And so, exactly as you said, there is this, I forgot the exact word you used, but a positioning thing. Like someone on the right wing has to say something. Even though there's no evidence for it, even though he knows no one's going to vote for it, and it won't make any difference in any way, but someone has to say it because he knows it's going to be relevant for the people that vote for him. So actually last year somebody did it. I didn't even expect that. But the interesting thing is that they didn't take us our main results, the results I showed you on access to the coverage, on healthcare consumption. No, they took another result that we didn't expect them, or actually we didn't want them to identify. Because when you estimate a percentage of people covered, I mean, and you have the total number of people covered, at the end of the day, it's quite easy, even from someone from the Senate, to make this the calculation, the estimation of the total number of undocumented migrants that you're going to. So you have like 300,000, at that time it was 3,100 people that were insured by the state medical aid, that the 50% would be covered. So you just multiply by 2 and you have 600,000. That's a big number. Nobody wanted actually to say, hello, hey, I have a new estimate for the total number of irregular migrants in France. It's not what you thought, it's much more. We didn't want that. And actually, for scientific reasons too, I mean, we're not demographs, right? We are economists. We're working on a take-up of the state medical aid, not on the total estimates of migration numbers. And actually, last November, someone said something on the for the migration law, and all of the press's releases were about the total number. And so there was this Paul Dourgnon or Irdes or someone said, my institution said, they are estimating the total number of migrants too, etc., which we didn't really do. We never published anything on that, but they made their own calculation from our own results for once, And so that was not expected. This is not what we wanted. The question is, was it worth doing it though? Like, I mean, I don't regret it. I think we had to do it. We had to shed light on the process. I mean, otherwise, what is our social added value, right? If we're going to do that, I mean, I'm going to go fishing or something else. I mean, I'm going to retire and that's it. So I don't regret it. But then that your question, I mean, was it's a very good question, and yeah, it's a long story made short.
Thanks. Also, the question to me was very good. The comparison between the UK and Spain, they are really two most different cases to compare, particularly in the sense that not just the political discourse, I mean, this was around 2015-16 when Spanish exceptionalism was still alive, while in the UK, Theresa May had just made the famous statement of now the official UK government strategy towards irregular migration is to create a hostile environment for these people in this country. An approach that many countries are following, but not very many politicians say it in this clearness, at least at the time. That paved the way to a certain degree also for that. And it's also in line with the overall perception and the legal frameworks for deportation and regularization. So for me, the whole access to public services of irregular migrants takes place between deportation and regularization. And in Spain, is in the European comparison one of the countries where regularization is most easily accessible and where the deportation system does not work very well. While in the UK had interior ministers who applied, went to the polls before a lot of an important part of their campaigning was the number of people that they were promising to deport every minute of their being an elected representative of the state. And that made an impression on the public, and also it's something that I realized made a huge impact on people who work in public services, because for them, an irregular migrant in the UK is somebody who has to be deported and will not have a chance to regularization. It's just not something that is being perceived as a way out of this situation. Whereas in Spain, it very much is. And so for a doctor to meet a person who they know in 2 years, they will probably be a regular migrant, and in any case, they will stay here. It makes much more sense to continue with proper treatment, rather than if you work in the UK and feel like this person will probably, as they promise me, be deported very, very quickly. Why bother so much with their health? And so yes, it totally trickled down into the everyday service provision. And in terms of for me, the most challenging thing of this was also, especially in Spain, to be presenting the case as always the better example, where obviously seen from within Spain and working a lot with, collaborating a lot with very critical and rightly so NGOs and networks who said that, well, but the situation here is not great, it's not super easy access. And I always had to say that, well, yeah, it's obviously understand this situation, but compared to the UK, it really is quite great. And so that was a very difficult thing for me to manage as a researcher in the field. And I hope I answered.
Okay, so yeah, thank you very much for the questions you posed as well. I will start with the second because in a way it links to Reinhard's comments. I would not say that Spain was a migrant-friendly country, not at all. What I would say is there was a combination of pragmatism combined with some level of empathy. But that empathy doesn't mean sympathy. It just means, you know, okay, I can understand the reasons why you left your country. As far as that does not affect me negatively, fair enough. Stay around and do your thing. So how did the Spanish system work, and continues to work, in fact? Through a very kind of tacit agreement among all actors not to talk too much about it and just let things go on their own rhythm. So what I mean by this is that undocumented migrants are incorporated into society through their participation in markets, done irregular markets for many years, and then gradually enter into more regularized markets. So how is this happening? Well, first of all, if you're an irregular migrant, you need to work irregularly. But everybody assumes that this is going to happen. And actually, everybody understands that the economy needs some of that. Would it be ideal if there was none of that? Yes, but then we would be Norway and not Spain. So we are Spain. So we need some spaces for irregularity in the agricultural sector, in the personal service sector, and in the tourist industry, just to mention some sectors, right? So everybody assumes that is the case. So it is kind of in a very perverse way, a win-win situation. Because, and let's say, for example, middle-class families that would never be able to pay real labor market prices to someone taking care of their children or their elderly parents or cleaning in their homes, if they had to pay proper salaries plus social security, they would not be able to afford that, right? So how do families in Spain get dual earners? So basically the husband and the wife or the two partners basically working by someone, by subcontracting, externalizing some of the tasks which are necessary in the home. But they could not pay real market prices for that. So there is a basic understanding. We pay a migrant much less than would be official, but good money compared to what this person would do would make it in her own country, and everybody wins in a way. Of course, this is very unfair. The person has not labor market rights. The person is living a relatively precarious life, has left her family back home. You know, in that sense, yes, it's unfair. In another way, this person is making 10 times more money she will be making back in her own country of origin, right? So the system has, in a way, established mechanisms to respond to that. For example, the automatic regularization after 3 years of living in Spain. This is an automatic process. It's done individually. It's not an amnesty. Okay, it's not a regularization process. We used to do those in the past, but they were very, very visible, right? The last one regularized 700,000 people in one go. That is very visible, politically speaking, is sensitive. So we created an automatic system by which every person, 3 years, no problems with the police or the judiciary system, becomes regularized. So it's a system of permeating people into society and emerging them into the legal system, right? So as I say, it was a pact, a tacit agreement, not to talk too much and let the system flow in that way. Well, now migration is much more visible, much more politicized by the extreme right, so things have become more tense. There is more talk about it, and there is more problematization of different things. So in the future, this kind of deal may be eroded or it may change, right? So as I said, it's pragmatism. And yes, when you ask people in surveys, do you think undocumented migrants should have access to healthcare? 80% of the people would say yes. But as soon as you start framing the issue differently, and we conducted an experiment with surveys a couple of years ago, and we asked basically people questions about one particular topic, but we framed the question differently. And in the control group, we just posed the question, do you think undocumented migrants should have access to healthcare? And we got certain answers, right? But then in some other groups, subgroups in the survey, we started with another sentence, saying things like, the resources to fund healthcare are under strain, and there is not enough money to pay for it. And then the question, do you think undocumented migrants should receive? And then the percentage of people saying they are in favor of that drops drastically. So the framing of the situation has huge effects on what people say they think or they believe, right? So if you insist over and over in a society that migration is a negative thing, and you repeat it up to extenuation, there will be plenty of people who will believe that. And that will end up having results in terms of what they say they think and what they vote, right? So that is the thing, the process, I think, is on happening, basically, or going on. So back to your first question about the different levels of administration. That is super interesting because it's what I put in my presentation as the multi-level governance structure of the healthcare system. And the more complex it is, the more complicated it is also politically speaking. So just to put one example, the relationship between the central government and the regions in every field of policy, but in particular in healthcare, is cut across by many different issues. To start with, which is the political orientation of the governments. So if the national government is left, but the regional government is right, there is going to be an issue there because they need to gain credits by antagonizing with each other. So that issue, the political kind of competition, if you want, between different levels of government, introduces one variable into the equation to understand the behavior of regions differently to the central government. The second one is the fact that these levels of government are competing with each other for power. So the central government is trying to hold as much power as it can. The regions are trying to expand their power to the limit, right? So in that tension, if the central government says, don't treat migrants, some regions are going to say, well, actually, I'm going to. And they are going to find a way to invent a code, right? And they will grant access to these people. And then the central government has taken the regions to the Constitutional Court on this. And he loses. The central government lost because the Constitutional Court said, well, everything that has to do with social policies is actually the power of the regions. So if they decide they want to do it, fair enough. So, you know, it's an issue of contention, politically speaking. And what was the last thing? Yeah, and then there is the other dynamic of going on between different levels of government, which is the logic of blame avoidance and blame shifting, which is basically putting the blame on the other, right? So if one region actually feels that something is not good, but they don't want to take credit for that, they don't want to recognize in front of their citizens that whatever they're doing is not properly done, they will say it's the central government who is doing something wrong, right? And the other way around, the central government doesn't manage to control certain parameters and he will blame the regions for that. So that is a constant dynamic going on in any federal state or decentralized state. And this cuts across everything having to do with healthcare policies, including the access of undocumented migrants to it.